Hi, this is Mark Struthers. This presentation focuses on the critical role of portable chest imaging in trauma cases in the emergency room. We will cover the different types of trauma, assessment protocols, imaging techniques, interpretation, and the integration of the findings into patient care. To begin, we will identify what is the role of the radiographer in trauma imaging. Number one is to confirm diagnostic quality with proper exposure, collimation, and patient ID. Number two is to recognize lethal 6 injuries. These include a tension pneumothorax, open pneumothorax, massive hemothorax, a flailed chest, cardiac tamponade, and airway obstructions. After looking at the lethal injuries, we spot hidden 6 injuries, which are pulmonary contusion, an aortic injury, tracheobronchial tear, esophageal rupture, diaphragmatic rupture, and myocardial contusion. The radiographer must support clinical decisions and rapidly help flag abnormalities for the trauma team in action. We will first review chest trauma causes and triage in the ER. Then we'll explore the benefits and limitations of portable chest x-rays in trauma evaluation. Next, we will discuss interpretation of common and subtle injuries, and finally we'll cover how imaging guides emergency management and follow-up. Integrating radiographic findings into clinical management enhances patient outcomes. Imaging guides interventions, coordinates with other diagnostics, and supports documentation and follow-up plans. Radiographers don't diagnose, but they play a frontline role in trauma care by producing a preliminary evaluation of images that may contain life-threatening findings. Their job is to recognize and not interpret, and to know what to look for, flag abnormalities, and ensure the image quality supports accurate diagnosis by the radiologist or the trauma team. In trauma, the portable chest x-ray is often the first image acquired, even before CT, because it's fast, accessible, and doesn't require patient transport. It's used in primary survey to detect life-threatening conditions. Although the standard positioning for trauma chest x-ray is the AP supine, there are differences in how we take the chest x-rays based upon air fluid levels in the chest. Let's take a moment to study these illustrations of lung markings on trauma radiographs and the influence of fluids or lack of fluids within the thorax. Here we see a right lung pneumothorax, where the air is pushing in on the right lung and shifting the heart and the left lung to the other side of the thorax. Let's see how the changes in volume of air within the thorax affect the chest. You'll see that as air pushes the heart and the other organs to the left, the right lung is losing all of the lung markings, and we can see very well the pneumothorax. As the lung collapses and air rushes in, it pushes all of the organs in the chest to the left side. By putting a chest tube in and releasing the air from the left lung, the pressure is released and the lungs return back to normal. We can see if the organs were shifted to the right lung, we would have had a left-sided pneumothorax. Next, we're going to take a look at how the lungs appear if the patient is in an upright position or in a decubitus position, and the lungs are filling with either blood or fluids. The first place to look for fluid in the lungs is in the costophrenic angles. Here we see fluid in the right costophrenic angle. We can put the patient in a decubitus view, and by leaving them for at least 5 minutes, we watch the fluid fall and the air rise, which gives us a different look at the air fluid levels. In the supine position, the fluid layers out posteriorly and produces a haziness, especially near the bases. Radiographers must understand the anatomical coverage required. We begin by recognizing anatomical landmarks such as the trachea, the carina, lung fields, diaphragm, and heart borders. We look at the rib cage, clavicle, spine, and soft tissues, and then we look for the lines and tubes. Let's talk about imaging technique essentials. The view selection. AP portable chest X-ray is standard in trauma bays. Lateral or orthogonal views only if the patient is stable and localization is critical. Include the entire thorax. Don't crop out external objects. Example would be impaled items or tubes. And you must master the accuracy of putting markers in the correct place and having enough documentation about the time and orientation of the anatomy in the room. If you see signs of tension pneumothorax or other misplaced lines, alert the physician immediately and use high kVp for penetrating injuries or dense foreign bodies and adjust the techniques for casts, dressings, or body habitus accordingly. You need to coordinate with the ER team and confirm when it's safe to image, and don't interrupt resuscitation. Image quality of the portable chest X-ray. You need to check for rotation, check the symmetry of the clavicles relative to the spinous processes. If one is enlarged, you're rotated. Rotation can mimic or obscure pathology, for example, a widened mediastinum. When viewing the chest X-ray, what you'll find is that midline structures like the trachea and the spine should be centered. Also try to get the exposure on full inspiration, ideally 9 to 10 posterior visible ribs above the diaphragm, because poor inspiration can mimic consolidation or effusion. In trauma imaging, especially chest radiography, radiographers are often the first eyes on the image, and their ability to flag the red flags clearly and respectfully is essential. Here's how we do it. Radiographers should be trained to recognize tension pneumothorax, which is a mediastinal shift or collapsed lung. Misplaced lines and tubes. For example, if the ET tube is too high or in the esophagus, chest tube could go down into the fissure and collapse the lung. We need to be able to visualize free air under the diaphragm because that suggests for perforation, and find foreign bodies that are ingested or impaled. A widened mediastinum shows us that there is a possible aortic injury, and a flailed chest or multiple rib fractures are very dangerous. When you get impacted on your tissues, it can drive air into the tissue of the muscle around the chest, and you can see subcutaneous emphysema also. Document your observations. Note in the imaging log or the PACS comment field. Radiographer observed possible pneumothorax. ER physician notified at 9:12. This protects the patient and the radiographer and ensures continuity of care. Inexperienced radiographers in the emergency room, especially under trauma conditions, can make errors that compromise image quality, delay diagnosis, or obscure critical findings. These mistakes often stem from pressure, positioning challenges, and lack of trauma-specific awareness. Positioning in trauma isn't just important, it's mission critical. In the ER, where seconds count and patients may be unstable, positioning directly affects whether life-threatening injuries are detected or missed. Another factor is medico-legal documentation. Trauma images often become part of legal records. Poor positioning may be challenged in court if it obscures injury or misrepresents the anatomy. Exposure technique in trauma chest imaging is absolutely critical. It's the difference between a diagnostic image and a dangerous blind spot. In trauma, where time is compressed and pathology may be subtle or life-threatening, the radiographer's control over the exposure, KVP, mass, SID, and grid use directly affects whether clinicians can act with confidence. An underexposure can obscure a pneumothorax, hemothorax, lung contusions, or misplaced tubes or lines disappear. An overexposure can wash out rib fractures, subtle lung markings, and mediastinal contours. Endotrach tubes, chest tubes, central lines must be clearly seen on the image, and exposure must balance soft tissue and device visibility, especially in a carotid trauma bay with overlapping artifacts. Trauma patients may be unstable, in pain, or immobilized. A poor exposure means a repeat image, which delays care and increases radiation exposure. Cropping of images or overcollimation in chest radiography is not recommended because it compromises both diagnostic integrity and patient safety. Trauma imaging must capture the entire injury zone, including entry and exit wounds, foreign bodies or impaled objects, and adjacent structures. Cropping or tight collimation may cut off key anatomy, leading to misdiagnosis or incomplete surgical planning. As we visualize this portable chest, one of the first things we'll take a look at is the endotrach tube. Notice the area of the carina, the bifurcation of the bronchus, main stem, right and left, is extremely important because this tube has gone down the right main stem bronchus, and because of that, we ended up with a collapsed left lung and a hyperinflated right lung. Line placement and tube placement is extremely important. If a patient moves during an exposure, if the exposure time is too long, we'll get a motion artifact. This is blurred anatomy and unreadable lung fields. To be able to fix this, we use shorter exposure times and communicate clearly with the patient or team before taking the image. Remember, you're there not to diagnose, but to detect. And if you detect something immediately, don't get too excited and show the doctor immediately. Take time to take a look and analyze the entire image. You don't want to overlook other injuries by focusing on the first one that you see. Mislabeling or indication errors are extremely important when doing portable radiography. Let's think of a couple things. How about wrong patient ID? Well, the patient goes up and has surgery and it turns out we've got the wrong patient. Or similar, patient goes up for surgery and we had our side markers incorrect and they amputate the wrong leg. It sounds ridiculous, but it does happen. So the impact would be legal risk, misdiagnosis, and treatment errors. To fix this, we need to double check identifiers before and after exposure. I've created a chart of common errors that happen during a portable chest x-ray being taken in the emergency room under chaotic conditions. This table shows the clinical impact and the correction strategy. Take a moment to study this so you'll understand and avoid these errors in the future. In a trauma situation in which EMS are involved, initial assessment and triage protocols are very important. Effective triage involves airway, breathing, and circulation evaluation, along with fast exams, which is an ultrasound exam for the abdomen and the chest, when indicated. Early indication of life-threatening conditions sets priorities for imaging and intervention when the patient gets to the hospital. To optimize trauma chest imaging in the ER, a radiographer must adapt standardized techniques to meet the demands and urgency of the current situation, the patient's instability, and diagnostic clarity. Chest trauma is a frequent and potentially life-threatening presentation in the ER. Understanding common causes and properly assessing patients on arrival is vital for timely diagnosis and management. Chest trauma often results from blunt injuries like motor vehicle accidents or penetrating injuries such as stab wounds. Recognizing the mechanism helps predict injury patterns and guides diagnostic focus and technique. Let's take a look at some of the common causes and mechanisms of chest trauma. We start with rib fractures, hemothorax, a flail chest, pulmonary contusion, and cardiac tamponade. All of these can be life-threatening. Among these types of injuries, the rib fracture is probably the least morbidity type of fracture that can happen. But we need to be able to visualize that. And with rib fractures, we have to be very, very cognizant of our exposure and positioning. When we have multiple rib fractures and bilaterally, what we're looking at is the fact that we can end up with a flail chest. This is extremely dangerous. As you can see by the image here, you have multiple rib fractures. On inspiration, what's happening here is that the heart is being pushed in one direction, and expiration is being pushed in the other. And also notice that the inspiration has the ribs caving in, and the expiration has the ribs pushing out. Cardiac tamponade is a life-threatening emergency where fluid, usually blood or inflammatory effusion, accumulates rapidly in the pericardial sac that surrounds the heart. This buildup compresses the heart, preventing it from filling properly and drastically reducing the cardiac output. Pneumothorax, hemothorax, and hemopneumothorax require the radiographer to be extremely critical in choice of exposure and positioning. We must be able to demonstrate lung markings, air, and fluid levels to determine whether that it is a hemothorax, a pneumothorax, or a hemopneumothorax. Remember, many pneumothoraxes and all are not very big, and the only way you can see it is a slight variation with the lung markings. Here we see a giant pneumothorax, and this is life-threatening and needs to be brought to the attention of the ER physician immediately. One of the things you have to take a look at is the difference in the lung markings. Notice that the collapsed lung has no lung markings, while the aerated lung does have lung markings. This is why technique and positioning are so important when doing a portable chest X-ray for hemothorax, pneumothorax, and tension pneumothorax. When a patient has a pneumothorax, the physician will normally place a chest tube in to reinflate the lungs. If it's small, they might not use a chest tube because it will reinflate by itself over a period of time. But it is important that you take images before and after the tube emplacement. Here we see the chest tube placement, and we see the pneumothorax and the re-expanded lung. For technique purposes, notice that it is best to get an inspiration and an expiration chest so that we can get the differentiation in the lung markings. When taking your radiograph, technique is extremely important, and positioning when looking for a chest contusion. Portable chest x-rays are indispensable tools in trauma settings, allowing rapid bedside imaging without moving unstable patients. They provide crucial information for immediate clinical decisions. Portable x-rays enable quick, safe imaging at a patient's bedside, reducing delays and risks associated with transport. This facilitates prompt detection of critical injuries and expedites care. Portable chest films complement clinical care and evaluation. They indicate suspected pneumothorax, hemothorax, rib fractures, chest tube placement assessment, and monitoring of critically ill patients. Awareness of limitations in portable chest radiography in the ER is critical to interpret results accurately and decide on further imaging. Challenges include suboptimal image quality, patient positioning, constraints, and potential for missed subtle injuries. Accurate interpretation of portable chest films is essential to identify injuries promptly. Radiologists and clinicians must recognize common and subtle signs to avoid missing life-threatening conditions. Let's take a look at the ER doctor's quick scan priorities in trauma chest x-ray. First, identify immediate threats. Look for tension pneumothorax, hemothorax, lung contusions, and subcutaneous emphysema. Next, verify tube and line placements. Check ET tube, chest tubes, central lines, and nasogastric tubes for correct positioning. Following that, assess structural damage. Spot rib and small sternal fractures, mediastinal widening, and diaphragmatic abnormalities. And finally, consider the clinical context. Correlate your findings with the mechanism of injury and patient symptoms to guide urgent care decisions. Subtle signs such as a mediastinal shift, small pneumothorax, or a diaphragmatic injury require careful scrutiny to prevent misdiagnosis that could worsen the patient's outcomes. Timely and clear communication of imaging findings to the trauma team facilitates coordinated care. Structured reporting and direct dialogue improve decision-making in urgent settings. Accurate documentation of imaging findings and subsequent management plans is vital. Follow-up imaging may be necessary to monitor progression or resolution of injuries. Here I put together a little table of the structure and the region of interest, what to look for, and possible findings. Take a few moments to take a look at each one of these. For the trauma chest, we're looking at more than the standard chest interpretation, which is generally the ABCDE method, or airways, breathing, circulation, diaphragm, and then everything else. We need to enhance this basic ABCDE with specific trauma values. In trauma chest imaging, once the radiographer confirms the image is diagnostic, meaning it's properly exposed, centered, and includes all the critical anatomy, their analysis shifts to a structured sequential scan of key regions. This isn't about interpreting every subtle detail, but ensuring nothing crucial is missing. Radiographers sequential image quality scan post-diagnostic check. 1. Lung fields. Are both lung fields fully visualized? Is there any sign of pneumothorax, hemothorax, or contusion? Number 2. Is there pleural spaces and costophrenic angles? Are the angles sharp and visible? Any fluid levels or blurring? Number 3, we look at mediastinum and trachea. Is the trachea midline? Is there any widening or shifting suggesting tension or vascular injury? Next, we actually take a look at the bones and soft tissues as well. Are ribs, clavicles, and spine intact and symmetrical? Any fractures, subcutaneous emphysema, or foreign bodies? Next, we look at the diaphragm and the upper abdomen. Is the diaphragm intact and properly contoured? Is there any free air or herniation? And finally, we look at lines, tubes, and markers. Are all devices correctly positioned? Are all anatomical markers accurate and visible? When an ER physician checks breathing in a trauma patient, whether by listening or portable chest x-ray, they're scanning for immediate threats to life and clues that guide rapid intervention. Airways are absolutely critical in trauma chest radiography because they serve as early indicators of life-threatening complications and help guide urgent clinical decisions. The trachea should be midline. Deviation may suggest tension, pneumothorax, or a mediastinal shift. When we take a look at the carina, which is the bifurcation point of the trachea, it helps us assess endotracheal tube placement. The right mainstem bronchus is more vertical than the left, and it's a common site for aspiration. And the left may be compressed because of a mediastinal hematoma. If we take a look at the bronchial tree, visible if surrounded by air bronchograms, it helps us identify contusions or collapse. And finally, we look at the paratracheal stripe, which is a thin, soft tissue interface adjacent to the trachea. Thickening or displacement may indicate hematoma or mass, or if around the T-spine area, a T-spine fracture. While AP portable chest x-rays are the default in the ER, due to speed and patient stability, lateral or orthogonal views can be critical in specific scenarios where additional depth or localization is needed. In conclusion, portable chest x-rays enable rapid evaluation of chest trauma critical for emergency room decision-making. And understanding the benefits and constraints of portable x-rays ensures accurate diagnosis and patient safety. This is Mark Struthers, and I want to thank you for your time and for your attention. Please subscribe to the Mark Struthers channel. We look forward to doing more projects for you about medical imaging and other areas of interest. Again, thank you for your time and your attention.